Right, right.
I mean, and they've been calling me out in their blogs and things by name because I sit on all 3 task forces. Of course, they don't understand who I am or what I do or what degree I have.
Right.
It changes from blog to blog. But, and it's disconcerting. I mean, it's disconcerting to me. I mean, I didn't know what today was going to look like. And, you know, I wondered, did I need to bring my husband with me to walk with me? I mean, I didn't know what to expect based on the amount of hysteria that seems to have been stirred up in their misunderstanding.
Well, it's easy to misunderstand what we...
With quite a bit, with the legacy problem, they felt that the evidence of harm outweighed the evidence of benefit, and that they put the taper in so that there wouldn't be a sudden cutoff of those patients who technically weren't getting opioids covered because it was an uncovered condition. So they did wrestle with that a little bit. And then you didn't get a chance, unfortunately, today to really look at the meat of the proposal. Currently, these conditions that we're looking at aren't covered, so theoretically these patients are not getting opioids. No. So I know there's been a lot of, I mean, you heard it today, unfortunately, with a lot of the folks. I think there's a lot of misunderstanding about our actual proposal. Our proposal is to allow coverage of opioids under certain conditions for 4 of those 5 chronic pain diagnoses. So I think there's been some wrestling with this already. The initial proposal didn't have that, and it's been modified at our previous meetings, both of the task force and at this task force. So
very vulnerable to kind of plug in and understand all these things.
Just really, at this point, you know, we aren't weaning all the people off of opioids. The only thing we have done was with Guideline Note 56, which we've been using for 2 years, 3 years.
Yeah, we shined a light on it.
Almost 3 years.
We've been using it for 3 years, and it was based off what we all thought was good evidence when we agreed and passed it, that opioids cause harm to that specific patient population. And so most of the CCOs in the state and most of the original fund patients have been weaned off, or at least we are no longer paying for them. What happens, you know, if they're paying cash or...
That's actually a really important point. This is not a state mandate. Like, it's not a law. The legislature's not passing it. It's a insurance coverage.
It's an insurance
but it has
coverage.
Which has implications, of course.
Yeah, for a Medicaid population, that's...
it's important to me that you understand.
No, I do understand. My sister lives in Ohio and is a chronic back.
Yeah, so, go. I'm sorry, we have some on the phone, too. Don't want to forget about you guys. Go ahead, Kevin.
Yeah, so a couple of things about the conflict of interest. The thing that's a little distressing to me is, you know, I think there's a overt conflict of interest when you're there to financially profit from something that you're testifying for. I think that is the original intention. But everybody has some sort of conflict of interest because you cannot escape your biases. And what is a little disturbing to me is, I understand trying to be completely transparent, but having looked at some of the evidence that is being put forth in support and some of the people that are testifying and applying information, the conflict of interest that they have is not being revealed. And so, you know, rather than I just want to make sure that we're aware that there are some heavily conflicted opinions out there that are not really based on what the evidence shows. And what I understood with the HERC is we're supposed to be able to, as best we can, as humans, to step away from those biases, to look at the available evidence that is out there so that we can evaluate that. And I'm hearing a lot of anecdotes that's being put forth as evidence, and a lot of evidence is being said, well, that's not really evidence because it's not what I believe to be evidence. So
Linnea.
I just want to say, actually, Dana, I think we appreciate OHA's caution because I think we don't want to end up being less credible as a decision-making organization or group. And so I think all of us know that people, I don't know about you, my LinkedIn, number of touches, I get an email. It's like people have been looking at everything and people have been scouring for these things. And we know that happens when people have a passionate belief about something and want to look at that rather than the topic. But I appreciate the caution that you and Mr. Allen exhibited today, because I think it gives us greater credibility when we move forward in this work, and that I don't think any of us are reactive to, oh, we should have done it today. I think all of us went, oh, okay. At least that was my sense. I wasn't here this morning, but my sense was there was a, okay, pivot. I mean, this is what we need to do to maintain credibility as the decision-making group around health evidence. So I don't think there's any concern for us, and I think we still have adequate opportunity to continue to look at the work. I do know that it was difficult today in hearing testimony because folks don't distinguish us from anybody who previously made decisions or other kind of information, and it does become more than professional criticism. It becomes slightly personal in some of those comments, and I hope that
Slightly?
well, I hope
I feel my entire profession is being attacked every single day.
Right.
Well, I hope that we as a commission can stand in support of each other, that we know, because we've all had patients like this in the course of our lifetime, or people that we've been with who have distorted sometimes the way, or are not entertain a conversation or a dialogue, but start on the offensive. And that's just difficult because it doesn't give us a place to find the common ground or the place to start the narrative that creates a relationship. So, I think everybody did a great job today, not rising to the, or being reactive. It's a little hard, and I know that the consumers are thinking that we just don't care because of our neutrality, but I think that we have to continue with that place of dignity of really saying, I'm listening, but I'm not going to give you an emotional reaction, which for me as a psychologist is not always easy. So I think it's I wanted to raise my hand. Like, are you answering? But we can't do that. And so I think we should feel confident that we acted in the appropriate way today and that we're taking the right steps forward, and that we'll work in concert.
Can I just say, because we can't respond and we can't correct things that are grossly, blatantly wrong. So most of these folks that are talking about their pain and the things that have happened to them are not things because of anything that we in the Chronic Pain Task Force or the HERC or Guideline Note 56 had anything to do with.
It's not 60,
It's
and
astounding.
yes, they did.
It's horrible. I'm embarrassed for my profession, but we did not do anything that caused them to be kicked out of their clinics.
They did.
You know, most of these folks, they have all these other processes. If you have MS, it's a covered service. You get opioids and whatever else you need. I mean, so I don't, lots of these stories don't fit with what it is we have done or what it is we're trying to do. And so I really need you all to understand, because this is so complicated, that for those of us that work in this every single day, I have 100,000 OHP patients. That is not what we are mandating that happens to any of them. What happens in the physician's office, we can't.
About what's covered and what's not, and what's real and what's not. And some of them are probably on narcotics today because they're in a covered line for something else that deserves therapy, and most of them probably don't have chronic pain as the diagnosis that's driving any coverage that they have. So
I just wanted to thank you all actually for being part of our body here, which is an open public body. We're really unique. And what I was hearing from a lot of the audience members was anger over decisions and things that we didn't do, but there's no public person to go and complain to. So they're mad at the CDC, they're mad at a state government perhaps, or they're mad at their doctor, but there's no way for them to confront them. So you're hearing that anger and that upset because we are an open public body that welcomes public input. So I want to thank you for being willing to be part of this.
But patients aren't getting it because physicians aren't getting it.
Right.
I just wanted to thank you all actually for being part of our body here, which is an open public body. We're really unique. And what I was hearing from a lot of the audience members was anger over decisions and things that we didn't do, but there's no public person to go and complain to. So they're mad at the CDC, they're mad at a state government perhaps, or they're mad at their doctor, but there's no way for them to confront them. So you're hearing that anger and that upset because we are an open public body that welcomes public input. So I want to thank you for being willing to be part of that.
That's good.
Pain management is primary care.
Yeah.
And it's team, it's both and.
All right, well, so I think it was good for us to commiserate a little bit about what we didn't do today, and also to feel a little bit of what we heard from that. So,
Yeah, and so we'll be
Can I just
sending.
ask one more thing, Dan?
yeah.
Is there any way to get better clarity, like Kevin had asked for, from them? Because I really feel like sometimes we are led astray. I mean, I felt like it with some of the drug things we looked at. Some of those people were not only paid to be here and talk to us, but they were from out of state and had all sorts of other conflicts of interest when they were talking to us. And so is there any way that we can standardize? I mean, because I know you guys say, can you please announce, name any conflict of interest? I guess the things that would matter to me is, are you here on your own behalf? Are you working for somebody else? And do you live in the state of Oregon?
I know
Can we
that
ask those things?
I know that the Pharmacy and Therapeutics committee has some form that they have folks fill out for testimony. That's the only body that I've heard do anything like that.
Every patient that was here today declared whether they had a conflict of interest.
Do you think
You're not very specific about it? I mean,
Well, I don't, that doesn't particularly speak to me. I mean, I don't think we have to make it more complicated than what it is, with people showing up who are expressing distress. They say they don't have a conflict of interest. I don't think that we have to go in deeper to try to find some kind of sinister motive from them.
I don't know that it pertains to this particular topic, but I think perhaps what Holly was referencing was one of the previous topics where the drug... I don't know that it pertains to this particular topic, but I think perhaps what Holly was referencing was one of the previous topics where the drug company paid for travel for people to come from out of state to testify on behalf of a drug therapy, and that wasn't disclosed.
and there was certainly times at our chronic pain task force where there was definitely people who were not fully disclosed about their backgrounds. And
Well,
even just-
I
even
think it's
just-
kind of tough. It's kind of
even just
tough.
with our Humira thing, we found out after with the
Still a long way to go in our chronic pain training, those of us who had to do that over the course of time. What we knew when we did that with our one-time 6 hours of chronic pain 8 years ago, or whenever that was instituted,
longer than that,
is different. Yeah, doesn't reflect the current level of information, and so there may be some other kinds of pieces that are outside of our jurisdiction and our responsibility that inform this, but we need to be aware of them and speak to. We can't change the culture of a provider culture that doesn't like chronic pain patients, and the issues of benzos as well as opioids has been a very difficult one for folks, but we know there are other things besides medicaid pharmacology to treat conditions, but we as a culture in healthcare haven't gotten quite that far with that as well.
No, just push
Was
it
there? I want to
down.
make sure. Did I hear somebody on the phone trying to chime in?
I don't know if, I just wanted to reflect, I don't know if you all saw, there was a JAMA article out last week which looked at death rates for opioids by all over the country, and only Oregon and Wyoming have seen a reduction. So something in our state's going right. We have no idea what, but just...
Yeah, I guess that one commenter might need to have that study given to her.
It just came out. It was in JAMA like last week.
Yeah.
So.
I wanted to say that.
Kevin, go ahead.
Yeah, so this is coming up again where people are like, well, we don't have the clinics to see these complex patients, and I know people look at me, and I can't see your faces, so I don't know what you're doing. But they look at me like I'm crazy, but the reason that we were recommending pain education for not only patients, but was for clinicians, is because pain is ubiquitous in the healthcare system. And you need it from the top to the bottom, and